Okay, welcome. My name is Oliver Lisenfeld. I'm the Chief Medical Officer of Inflammatix. And today I will talk to you about the need for actionable results to diagnose acute infections and sepsis in the ED, the power of host response. And this is the second webinar in a series for SAM on host response. I will divide my presentation today in three different sections. I will introduce you to the background and clinical need, the diagnostics with actionable results for suspected infections and sepsis. I will then use clinical vignettes to make the point of what an ideal host response test should look like. And then lastly, I will introduce you to Inflammatix INSEP testing solution that, as we speak today, is not yet FDA cleared. To introduce the topic, we all agree that managing suspected infections and suspected sepsis in the ED is a balancing act. And when we look at the two pieces of information we need to balance, we have on one hand the fear of sepsis, which makes us administer antibiotics early on and do other actions. On the other hand, we have to be very good antimicrobial stewards, thereby not over-prescribing antibiotics. And the requirement to act early in case of suspected sepsis by some people have even been named sepsis hysteria. So we can argue whether this is the correct term or not, but we all know this is a balancing act when we see patients in the ED. So why is that? The underlying causes for this are a mix of the lack of sensitivity of the currently available diagnostic solutions, the lack of actionable results that currently used biomarkers provide, and lastly, the biology of the infection, where local versus systemic infections obviously lend itself to very different infectious disease diagnostics, and a blood culture, for example, will not detect a local infection. So a good example for how hard it is to find a pathogen is this publication from Giant et al. From the New England Journal in 2015. What the team did is looking at over 2,000 patients with radiographically confirmed pneumonia, and patients underwent a whole series of different diagnostic tests that are applied under standard of care. But in the majority of cases, in 62% of these subjects, there was no pathogen detected. So we clearly have a problem using pathogen identification as a way to manage patients with suspected infections and suspected sepsis. When we talk about respiratory tract infections in the ED, it is also stunning that for visits for acute viral upper respiratory tract infections, that 30% of these subjects are prescribed antibiotics. And that is mainly in the adult population, as you can see in this graph from the CDC. While a decline was seen in the two different time periods, the decline was not seen for ED visits by adults, thus leaving room for improvement in the diagnostic space. A couple of years ago, Prescott et al. Introduced a new concept of how to look at patients with suspected acute infections and suspected sepsis. So what the team developed was a model where you would have two axes of sepsis, of which one depicted here on the y-axis is the question of whether or not the patient has an infection. On the x-axis, the question is how severely sick is the patient. And using these two axes together, we can try in an ideal world to put patients into one of four quadrants. The first quadrant on the bottom left would be a patient that is non-severe and not infected and can safely be sent home without any antibiotics. A patient that is severely diseased but not infected obviously requires further diagnostics and may have to go to the ICU. In the top left corner, we have subjects that are non-severe, but are infected. And these patients obviously require antibiotics and are discharged home. And then lastly, and most severely, the patients with full-blown sepsis require broad-spectrum antibiotics and have to go to the ICU. So what do we do today to try to approximate this allocation of patients into these four quadrants? We throw a whole kitchen sink of different tests at these patients to make sure we get the diagnosis and prognosis right. On the y-axis, you see that we use biomarkers like procalcitonin, C-reactive protein, and a white blood cell count. But we also use a lot of microbiology and virology testing like blood cultures and PCRs. For the determination of severity on the x-axis, we use lactate as a biomarker, and we use clinical scores. But all of these together are not ideal and not always allow to put patient into the right of these quadrants and thereby allowing the right management decisions. So host response used as a diagnostic and prognostic tool could be a paradigm change to allow for actionable results rather than what we currently have as standard of care. What we're showing here on the left is an ideal host response test and the readout it would come with. And on the right, you would have the potential clinical actions that are associated with these results. So let's look at the left panel. What you would ask for in an ideal world when you see a patient is, what is the likelihood of a bacterial infection? What is the likelihood of a viral infection? And what is the severity of the condition? And we're thinking about 7-day need for critical care interventions as a readout. The result readout of that test should ideally come with a score and should also fall into distinct interpretation bins that allow us to take the right decisions. What you see here in the color coding is basically on the left-hand side, the very unlikely or low likelihood bin. This is characterized by very high sensitivity and allows you to rule out either a bacterial infection, a viral infection, or the severe condition. On the opposite end, in the red bins, you have the very likely condition for bacterial, viral, or severe, which comes with very high specificity, thereby allowing you to rule in a patient into these categories. So when we look at the potential clinical actions that come with these results, for the likelihood of a bacterial infection result, you would be enabled to make a decision on whether or whether not to administer antibiotics. And you will also be empowered to consider other differential diagnoses should the result be unlikely or very unlikely. Similarly, for the viral infection likelihood in the middle panel, you would be able to consider isolation precautions in the presence of a viral infection, but you would also be empowered to go for other differential diagnoses should the result be very unlikely or unlikely. And lastly, for the severity readout, the 3 interpretation bins would allow you to make disposition decisions, whether to send a patient safely home, whether to admit, or even send to an ICU. So while this result readout is a hypothetical presentation for the ideal host response test, let's look into clinical practice. How could this be used and translated into clinical actions? I will present to you one clinical case, but with 3 separate result readouts that would take different courses of action. So let's look at the case on the left-hand panel. This is a 69-year-old female patient that presents to your ED with subjective fever. The medical history is significant for COPD, and she is an active smoker. The vitals come back as depicted here. The pulse of 95, a blood pressure of 125/83, a respiratory rate of 25, and a temperature of 37.5. So a somewhat inconclusive mix of vitals, a little tachycardia, and a slightly increased respiratory rate. The diagnostic tests that you have at the time of seeing this patient are a white blood cell count that is elevated to 24,000 with a left shift. Lactate is somewhat intermediate at 3.9, and the CRP is kind of low at 7.8. So now with this ambiguous clinical presentation, what would you do in your current standard of care situation? You would probably consider a multitude of different differential diagnoses. You would order a battery of different tests, and you may have the patient undergo a couple of procedures to figure out the true diagnosis. So let's think about the result readout that could come back from a host response test, as we discussed. Let's imagine the bacterial result comes back as a very likely, so a high likelihood of 37. The viral result comes back as 10, very unlikely. And the severity comes back as 31, very likely. So now, in this case, your course of action would focus on immediately initiating antibiotics, admitting the patient likely to an ICU because of the severe condition. And you would likely shy away and avoid to order a whole battery of other tests upfront to come up with other differential diagnoses. So you would focus on a bacterial infection as the mainly cause of this presentation. Now let's look at the same case presentation with a different result readout. What would happen if the bacterial likelihood score would be very unlikely with a score of 7? The viral score would be 31, very likely, and the severity would be 8, very unlikely. In this particular case, you would consider to give antivirals if you're in the season, like a Tamiflu or newer drugs, but you would shy away from antibiotics, and you could potentially send this patient home based on the low severity result. Again, same case presentation, very different result of a host response test, helping you to make very distinct clinical actions. In the last result readout I want to present to you, we're looking at the same patient, again with this ambiguous presentation, and what's coming back from this ideal host response test is a result of B7, very unlikely bacterial, V5, very unlikely viral, and S30, very likely severe. So here, very different from the other two result readouts, you would very likely not provide antibiotics or antivirals to the patient, but you would definitely focus on other differentials, a flare of COPD, a thromboembolism, and you would admit the patient. And using the host response, you would basically avoid that the patient gets treated with drugs or undergoes procedures that can actually harm him, rather than going after the right etiologies like an autoimmune disease or a thromboembolism. So the ideal host response test with the result readouts I've just presented are the results that will be presented by the INSEP test for acute infections and sepsis. So how does this test work? It's based on 29 host mRNA targets that are amplified by isothermal amplification. A machine learning based algorithm is then interpreting the results, and you are seeing the absolute scores that fall into the distinct interpretation bins I've just shared with you for actionable results. The test and instrument itself provide the results based on 2.5 ml of blood with a turnaround time of less than 30 minutes. So it is point of care-able. So to come back to the concept of the two axes of sepsis that Prescott introduced, what would the host response test add to your clinical decision-making? You would be having more accurate results compared to the biomarkers to determine whether this is an infection or not. You would have faster and more sensitive microbiological results to determine whether this is an infection or not. you would be more accurate in determining the severity of the condition. And lastly, taken together, you would get highly actionable results for early decision-making. So your upfront decision-making in an ED would be improved. In summary, what I've presented is that actionable results to diagnose acute infections and sepsis are provided by the INSEPT test for early decision-making. The test is easy to perform from a blood draw of 2.5 ml, takes less than 30 minutes in a point of care setting, provides 3 results: the likelihood of a bacterial infection, the likelihood of a viral infection, and the condition severity, and therefore gives you support to make decisions on whether or whether not to administer antibiotics, thereby taking away the ambiguity, but also to make decisions on the disposition of your patient, whether to send home safely, to admit to a ward, or to an ICU. I thank you for your attention. If you want to learn more, please visit inflammatix.com. You can talk to us over email, but you can also follow us on Twitter and LinkedIn.